I'm delighted to introduce our speaker for the day, David Eng. And David is a founder of Bunker Hill Health, and he is a Stanford alumni. So he received his BS and master's in computer science from Stanford. And I know he's been very active with a lot of the work that's been associated with the AIMI Center, particularly a lot of the work revolving bone health, and he's done a lot of great work in that regard. But today he's here to share a hot off the press publication that talked about automated coronary calcium scoring using deep learning and how this generalized to a multi-center cohort. So with that, please take it away, and thank you for joining us.
Thank you for that great introduction. And welcome everyone, and thank you for coming today. I'm David, and I'm really excited to be able to talk about our work, which, as you can tell, is fresh off the press from a couple of weeks ago. And before I get started, I feel it's important to acknowledge everyone in the author list that you see who each contributed to making our final publication as impactful as I find it to be. And I hope to anyone listening right now, anyone you'll find it to be as well. Cool. So I guess to get started, as many of you are likely aware, heart disease is consistently among the deadliest diseases in this country. In fact, it was the most common cause of mortality in the US in 2016. And within heart disease, coronary artery disease is the most common type of heart disease and was responsible for over 350,000 deaths in the US in 2017. And that's nearly a death every minute. So this is a very large clinical problem. And as we'll see, there are some exciting solutions that we can think of in addressing these problems.
Hey, David, just one note. We see your full Chrome window right now. I wasn't sure if you wanted to be in presenter view or just go through the slides. Just wanted to let you know.
Okay, yeah, sounds good. I think my presenter view makes things a little weird on my computer. So is
Perfect.
the text large enough for people to see?
Yeah, that's perfect. Just wanted to make sure, yeah.
Okay.
Thank
cool.
you.
So regarding risk assessment, fortunately, risk assessment allows for primary prevention of coronary events. And in particular, the long asymptomatic latency period of coronary artery disease provides a window for opportunity for early preventative intervention. The catch, of course, and there's always a catch, is being able to characterize the disease early enough in its progression such that treatment guidelines pertaining to the initiation of statins in antihypertensives are actually effective. And with that comes along comes the current standard of care, which is coronary artery calcium scoring, or CAC scoring for short, using gated coronary CT. This score, which ranges from 0, which indicates no calcification, to in the thousands, which indicates severe calcification, turns out to be one of the most informative predictors of coronary artery disease. And for those less familiar, gated coronary CT refers to the fact that the images are acquired on specialized hardware using ECG gating to eliminate artifacts resulting from motion of the heart. And once the CT is acquired, it gets sent to specialized technologists who manually segment the coronary arteries to yield a score. So despite the benefit to the patient in performing a gated coronary CT and computing a CAC score, there are a few limitations with this current standard of care. First, it depends on specialized technologists to perform time-intensive workflows. Second, it requires health systems to invest in expensive and specialized equipment. Third, It normally asks patients to actually pay out of pocket since this exam is not reimbursed. And in part for this third reason, fourth, these tests are rarely ordered for asymptomatic patients. In contrast to these limitations, we identified an enormous potential opportunity in being able to estimate risk in the form of a calcium score using a non-gated CT. Since several million non-gated routine chest CTs are required every year in the US for non-cardiac indications, an automated approach for calcium score on these studies addresses all of the aforementioned limitations in the sense that it would not require specialized technologists or specialized equipment. And importantly, it would not ask patients to pay out of pocket since routine chest CTs are required anyway for other indications, and it can be used opportunistically to identify even asymptomatic patients. Today, coronary calcification is not reported on these exams usually, and even if it is reported, only qualitative assessments in the form of mild, moderate, severe, or very severe are performed. With this in mind, we set out to automate calcium scoring from non-gated chest CTs. And to start out, we identified a very specific cohort. That is patients who received both a gated coronary CT and a non-gated CT within 1 year of each other. We extracted the non-gated CT as well as the calcium score from the gated coronary CT. It's worth mentioning that the paired data set that we acquired actually deviates from what's widely been reported on this topic in prior literature, in which the gated coronary CT would be disregarded, and instead the calcium score was quantified via manual segmentation of the non-gated CT. And the fact that we did use paired gated and non-gated CTs is a very important decision, which I'll return to later. As far as sites who contributed to the study, 6 total sites contributed the aforementioned data set, and Stanford and Mesa were considered internal data sets, and those data sets were split into training, validation, and test sets. The training split used to develop the model, the validation set used as a development set, and the test set used as an internal test set. The 4 remaining sites, DASA, MedStar, Palo Alto VA, and UCSF, were considered external data sets and only used as test sets. With that, I'll cover briefly how the algorithm was designed. And the algorithm was designed in 2 major components. The first component was trained to segment coronary calcifications on the input. So we take the input, it is provided to the first step of our AI process, and predicted segmentations of calcifications are produced. For training, a board-certified radiologist tirelessly manually segmented coronary calcifications on the non-gated CTs, labeling each one as a calcification of either the left coronary artery, the left anterior descending, the left circumflex, or the right coronary artery. With this ground truth, an encoder-decoder architecture was used to predict 5 values for each pixel in the non-gated CT. The first value was the probability that the particular pixel contains calcification, and the other 4 probabilities were probabilities or categories of that pixel being each of the 4 coronary arteries mentioned earlier. During training, cross-entropy loss was used for the artery-specific classification head, and dice loss was used for the binary segmentation head. From there, the second step, or the second AI step in this process, was to produce a estimated calcium score from the already segmented calcifications output by the first step. And for training, a gradient boosted decision tree was used to predict the calcium score from summary vectors for slices with the 5 highest predicted areas. This algorithm was trained using the aforementioned datasets, and then external validation was performed on a multi-institutional hidden test set from 4 external institutions disjoint from any of the institutions providing data for training. This external data set spanned different scanners, patient populations, and disease prevalences. Oops. Overall performance at various calcium score cutoffs were extremely promising. At the cutoff of 1, the positive predictive value of the model was 93%, indicating that when the model claimed that a patient in the external cohort had a calcium score of greater than or equal to 1, 93% of those patients actually had a calcium score of greater than 1, as indicated by the pair-gated coronary CT. Across the board, positive predictive values at external sites were high, ranging from the mid-80s to the mid-90s in percentages, while negative predictive values at lower cutoffs, i.e., if a patient had actually had a gated coronary CT calcium score greater than 1, 81% of the time, the model actually detected that that patient had a calcium score of greater than or equal to 1 based on their non-gated scan. These values ranged from 81% all the way to the high 90s for the cutoff of 400. In particular, we were interested in site-level performance at the calcium score cutoff of 100. And the reason for that is because the ACC and HA cholesterol guidelines recommend using statin therapy to reduce risk when the calcium score is greater than or equal to 100. And so really being able to discern whether a patient would have had a calcium score of greater than 100 had they been administered a gated coronary CT is an extremely clinically relevant task to evaluate the effectiveness of our AI model when producing results on non-gated CTs. And what we saw was across sites, high positive predictive value as well as negative predictive value at this cutoff. Positive predictive values ranging from 88% to 100%, and negative predictive values ranging from 86% to 93%. Together, this implies that if this model is to be used and deployed on non-gated CTs, it will not only yield few false positives, i.e. false alarms, to patients who do not have coronary calcification, who do not have high calcium score, but also be able to catch a high proportion of patients who do have high calcium score and, according to guidelines, should be started on statin therapy. In terms of specific example cases of this algorithm in action, we see it performing well across many, if not all, risk classes. Of particular note is the differentiation between coronary artery calcium and aortic calcium, the latter of which is less relevant to determining risk of developing coronary artery disease. Here we see several slices from a patient in the external validation set who does not have coronary calcium. The algorithm predicted 0 coronary calcium, and we see that no coronary calcium is present. Next, here's an example of a patient who demonstrates severe coronary calcium. In this case, their predicted calcium score was estimated by the model to be 241. And qualitatively, we can confirm that this patient indeed has severe amounts of coronary calcium. Importantly, we see that calcium of the aortic arch is correctly not classified as coronary calcification, while coronary calcification of the left anterior descending and left circumflex arteries are correctly identified. Similarly, this is a somewhat interesting case where aortic calcification is ambiguously differentiated from calcification of the right coronary artery. And in this case, the algorithm picks up on a portion of that calcification, more likely to be calcification of the right coronary, but not the rest of the calcification, which is more likely to be aortic calcification. Next is an example of a case with moderate risk level in which the algorithm predicted a calcium score of 35. In this case, there is extremely localized coronary calcification in the left anterior descending across 3 slices. Furthermore, there is again aortic calcification in the aortic arch, which is correctly not classified as coronary calcium. Here's an example of a study in which there's severe or highly severe coronary calcification. The patient is given, or the algorithm computes a score of 527, corresponding to a lot greater than the cutoff of 100. And here we see a extremely evident 2-vessel disease, both calcification of the left anterior descending as well as right coronary arteries. Finally, here's an example of extremely mild calcification in which the algorithm produces a score of 10. Here, there is only a single slice containing a small amount of calcification in the coronary artery calcification. These are the patients who we might assume, if left unchecked, would develop more severe calcification over time. And potentially, this algorithm can be used for early detection and implementation of preventative measures. Earlier, I promised that I'd discuss the importance of the ground truth that we chose. That is, instead of manually segmenting the non-gated studies and applying the deterministic Agatston algorithm on the resulting study paired with the original non-gated CT to produce a score, instead using ground truth from the paired gated coronary CT, and this decision was originally made to more accurately reflect the calcium burden as defined by the current clinical standard. Importantly, it is not current clinical standard or standard of care to evaluate calcium score on non-gated studies due to the presence of artifacts, particularly motion artifacts. As a result, we hypothesized that the calcium scores from paired gated coronary CTs are more accurate than any calcium score that you could potentially derive from the non-gated CT. And what we found was that this is actually the case. And this ground truth, this decision of ground truth was extremely important in reporting reliable results on the performance of the algorithm. To demonstrate this, what we did was we looked at the MESA test set. We chose the MESA test set for this purpose because the paired studies in the MESA test set were guaranteed to be acquired on the same day. And so as a result, the likelihood that gated and non-gated scans would differ in calcium burden due to progression of the disease between the two gated coronary and non-gated studies was minimized. And on the left, what we show is a trained segmentation model. That is the performance of the model if we had used the board certified radiologist's manual segmentation, the quantification of the board certified radiologist's manual segmentations as ground truth for our model. And what you see is a model that does not take into account the paired gated coronary CT whatsoever in this regard, demonstrates extremely high agreement. On the x-axis of this confusion matrix, we have bucketed calcium scores predicted by the AI algorithm. And on the y-axis, we have calcium scores as quantified by the manual segmentation by the board certified radiologists. And intuitively, this makes sense because there should be high correlation in application of a deterministic quantification algorithm. And there should be high agreement if there's high agreement between the predicted segmentations by the model and the manual segmentations by the board certified radiologists. However, to demonstrate the importance of ground truth, what we also did was took those same predictions from the AI model and then compared them to the ground truth calcium score as derived from the gated coronary CT. And what we found was, although use of the former ground truth shows an extremely high agreement and high performing model, on the right, we see that the true performance as determined by the ground truth from the gated coronary CT tells a much different story, where agreement is extremely low. And in fact, the model oftentimes underestimates the true calcium score of the patient. In terms of why we're really excited about this work as a whole, is the algorithm can really be used in many different ways, in the sense that it's very versatile and can implement, and the implications on the potential implications on standard of care are enormous. Two use cases you can imagine are radiologists receiving a calcium score in their reports and segmentations in their PECs at the time of interpretation. And second, you can imagine it being used as more of a quality assurance tool, in which administrators receive a weekly list of patients with high calcium scores from the past week. In real time, you can imagine that same calcium score, 150 for a patient, for example, that is produced by the model could be directly inserted into a radiology report. Or in the quality assurance case, patients with high calcium scores could be consolidated in some sort of weekly digest for health systems to ingest. Both of these use cases sort of tie into the future work or future potential research avenues for this algorithm. While this work largely demonstrates the scientific validity of the deep learning approach that we developed to predict calcium score from non-gated routine chest CTs, several clinical questions remain in order to determine in order to fully define how impactful this might be to patient care. Among these questions include what the most important factors are to ensuring high-risk patients, as determined by the algorithm, receive proper treatment. These factors might include PCP education, or the method or contents of the communication with the PCP. A second avenue of future work involves determination of the proper care pathways for patients with high incidental calcium scores, and what procedures and tests should be performed after these follow-up encounters. And finally, as I mentioned previously, there exist, the AHA and ACC have defined existing guidelines or existing treatment guidelines based on calcium scores from gated coronary CTs. However, it remains unclear to what extent these guidelines translate to patients identified opportunistically from routine chest CTs. And with that, I thank everybody for listening today. That's the conclusion of the presentation.